Dave Volk. I am in St. Louis, Missouri, and I have I'm the leader of the Keep in Touch group here in Missouri and Southern Illinois. And we've combined with some people from the Chicago, Northern Illinois group also. And we're fortunate to have Dr. Weihl give us a presentation and to answer some questions at the end. I guess Rachel's planning on recording his presentation and then stop the recording once we start. He'll take questions at the end. So if you want to put your questions in the chat box ahead of time, you can, and then I can ask Dr. Weihl the questions and go from there. Rachel reminded me that this is that May is Myositis month, and I guess what's the activities for May for TMA? Yeah, Rachel.
Oh, we have so many activities. I would go to our myositis.org page, and if you scroll all the way down to the bottom, you'll see 4 quadrants. In the bottom right quadrant, it says May is Myositis Awareness Month, and you will find all our programming. It's just insane how much we're doing this year with our new ED, Paula Eichenbringer, and I'd really like you guys to meet her on April 11th. We're doing a meet and greet leadership series that also has Dr. Namita Goel on it with us to talk about the purpose of the Medical Advisory Board, which Dr. Weihl was so gracious to be a member of previously. So yes, we're excited to observe the month. So thank you.
Great. Should I jump in, David? You're muted. David, you're muted.
Go ahead and jump in. You can start sharing your slide.
Yeah. Thanks, Dr. Weihl, for joining us. Appreciate you joining us. And I guess give us a little bit of background and then tell us about the myositis.
Sure. So thanks, David. So I'm a physician scientist. I'm in St. Louis, Missouri, and I did my neurology residency and then did a neuromuscular fellowship, and that's how people get into the field of of myositis. And so I have a research program as well as a clinical practice. I see patients really just 1 day a week, and then the rest of the time I'm performing research in our clinical research group as well as a basic science research group. And I thought I'd talk just about IBM as well as myositis, and then I'm happy to answer questions about both. I'm going to share my screen. Give me a second here. And everyone can see the screen? Okay. So I'm gonna see if I can get started here. So I thought I would just frame it initially just on kind of what myositis is, just so that we're all on the same page. And really it's very simple. It's inflammation of muscle, and in particular skeletal muscle. It can happen for a lot of reasons. It can happen because you actually have an infection in your muscle. Most people who had an infection in their muscle, it would get worse and then better on its own. But the type of myositis that we focus on in as causing kind of chronic disease is that which is an autoimmune inflammatory muscle disease. And that's usually due to a dysregulation of the immune system. And so people have heard of autoimmune disorders similar to multiple sclerosis or lupus. It's a disease in which the immune system, which is normally supposed to protect us from invading organisms, actually starts to attack our own tissues in a variety of different ways. And so arthritis, it's attacking the connective tissue in your joints. For myositis, it's affecting your skeletal muscle. And so this is what the type of inflammation that you can have in an inflammatory muscle disease. And so really the best way to diagnose and inflammatory myopathy is by muscle biopsy. It does not have to be by muscle biopsy, but that is one way that we can make the diagnosis. And the reason is because, as you can see on this, and you guys can see my pointer, I think, correct? I'm going to take that as a yes, but so you can see here on the left, there's a large area of what we would call intramuscular inflammation, and so that's where we can see this area of inflammation that's surrounding or within the skeletal muscle. This is actually skeletal muscle here, so this is a muscle fiber. And then over here, you can see the muscle is invaded with immune cells in a different place. It's actually outside of the muscle. And so this is why a muscle biopsy can be helpful, because it can help us understand if the inflammation is within the muscle, is outside of the muscle, is in some of the connective tissue that is surrounding the muscle. And the reason that's important is because that can help us understand the type of myositis, but also can help us understand perhaps what treatment would be best. And myositis comes in several different categories. So one is called polymyositis. Another is dermatomyositis. And then we have another form that we call necrotizing myositis. And then finally, inclusion body myositis. And each of these can be treated differently, and each of them looks different, although they can seem similar because they cause weakness and other symptoms, but they all are very different, distinct disorders. One way of diagnosing that has really become important is myositis-associated antibodies. And so myositis-associated antibodies are really something that have emerged over the last decade, and even more so in the last 5 to 7 years. And that is that we can often make the diagnosis and subcategorize myositis by looking at the autoantibody profile. And so we've now started to categorize myositis by their autoantibodies. And so there's a form that we call antisynthetase antibodies. These are all associated with intracellular antigens, and they just go by this name. Dermatomyositis has a specific subgroup of antibodies. The necrotizing myopathies do, and even inclusion body myositis, which we would not have thought would have an autoantibody associated with it because it's often not responsive to immune medications. It actually has an autoimmune antibody that has been characterized. And so how is the diagnosis of myositis made? You really do need to go see a specialist, somebody who understands myositis and the way to diagnose it. That can be either someone like myself, a neuromuscular specialist, or a rheumatologist. Often rheumatologists and neurologists think about things a little bit differently. And so it's not unheard of that patients will often have a rheumatologist and a neurologist. But the expectation that we're both going to think about things the exact same way is probably not the case. We have actually just started a myositis clinic at WashU that has rheumatologists and neurologists in it. The way that we do it is really by taking a history, so listening to the patient, performing an exam. We do a variety of ancillary tests, and these can be an EMG or nerve conduction study test. That's where we stick a needle into the muscle and we see if the muscle has electrical activity that would be abnormal. We do a variety of different blood tests. Sometimes we can do an MRI, and then often we do a muscle biopsy. I want to say that every patient is different, and every one of you is going to have a different experience. And And the issue is that there's rarely a textbook case of a specific myositis. And so often different physicians look at things in different ways. And there are many different types of myositis that can overlap or can have mixed pathologies, or people can have different antibodies or even can have no autoantibody. And so I just think it's really important that we not think that we need to have all the same features that other patients have, and to really realize that everybody is a bit unique. Why is it important to get a more specific diagnosis? So I would say, you know, it's important because it can help us understand the type of treatment and what you might be responsive to. And whenever I say a more specific diagnosis, that means if you haven't had autoantibody testing done, it might not be unreasonable to get a muscle biopsy at some point because it can help. But it can also help us understand other complications. Some myositis are associated with malignancy. But I want to be cautious that that it's not intended to confuse the patient or suggest that a previous diagnosis was incorrect. It's really just refining and understanding it. If you got 20 myositis physicians in a room, we wouldn't always agree on everything. And we just were at a meeting where many people disagreed. And it's not that they disagreed to the point that it changes management, but they disagreed to the point that it probably was confusing and would be confusing to a patient. And that's just because we're still learning more and more about these disorders. So I'm going to talk a little bit more about sporadic inclusion body myositis. There are hereditary forms of inclusion body myopathy. These don't have itis, so these don't have inflammation on them, and that's how we set them apart. Sporadic IBM is a rare muscle disease. The prevalence has been suggested to be about 10 to 50 in a million. And so that's a rare disease. Its onset is greater than the age of 50 in about 80% of patients, and 60% of these patients are often men. And why there's a predilection a little bit for men is unclear. It causes really this very slow form of weakness. Often patients, by the time they presented to a physician, may have had weakness for several years and not have appreciated it, or have slowed down, or have been told that they're just getting older and that they should expect to be getting weak, and maybe that led to a latency in their diagnosis. So it's a very slowly progressive muscle disease. It preferentially affects the quadriceps, so the knee extensors, and often muscles in the hand. What would a muscle biopsy look like? I like this image here because this image has all of the features that we would look for in a muscle biopsy for a patient with inclusion body myositis. It's unique in that it has inflammation. So this is inflammation. These little blue dots here are inflammatory cells that are actually starting to invade this muscle fiber here. And then there are features that we call inclusions or aggregates. And so this is a vacuole here, and then you can see these dark red aggregates here. And so that's what gives it its name, inclusion body, because of these aggregates that we can see in the muscle and because of the inflammation. And we're going to dive a little bit deeper into each of those features in a minute. This is the diagnostic criteria that was developed in 2013. And I want to just go initially to how these diagnostic criteria are created. And so this is a working group that was developed in 2011. And they came up with what they thought were the diagnostic criteria for inclusion body myositis. Inclusion body myositis and many of the myositises are really relatively new diseases. Inclusion body myositis itself wasn't described until 1971. That doesn't mean it wasn't around, but no one really understood it. And so in 2011, the goal was to try to come up with a diagnostic classification. And I would say that this diagnostic classification was actually somewhat confusing because it had probable versus clinically pathologically defined. And what we've learned is actually the diagnostic sensitivity of those in 2013 was actually quite poor. And sometimes 15% of patients weren't actually captured whenever we got really restrictive for the diagnosis. And so even the original diagnostic criteria in 1995 did a really poor job of actually diagnosing patients with inclusion body myositis. And that might explain why that prevalence is ranging from 10 per million to 50 per million because of the way that we do the diagnosis. And this is an example of if we start to include all of these detailed pathologic features, we actually lose a lot of the sensitivity for the diagnosis. So because of this, we actually created a new set of guidelines, and this actually just came out. This came out almost a week and a half ago. This was a meeting that I actually organized in the summer of 2023, and I called it 10 years of progress that we needed to revise the diagnostic criteria. And so I put up here the diagnostic criteria, not to make it look any easier to understand, but I want to point out a couple of things that we did. One thing that we did is that we didn't leave people in a category of questionable, of probable, or clinically defined. We either made the decision that if we were to come up with this algorithm, that you would have IBM or you wouldn't have IBM. So that's one thing we did. The other thing we did is we took into account that many patients have uncommon presentations. And so where we had thought that the age should always be greater than 45 years old, we do know that some patients get this at less than 45, and that some patients have higher than normal elevated CKs, and patients can actually have a presentation different features, such as weakness of their neck or trouble with swallowing, that can actually happen before these common features. And so that's one thing that we did. The other thing that we did is we added the autoantibody, and we added an MRI or potentially a muscle ultrasound as ways of helping to diagnose this disease. These weren't included originally. And so we do still keep that patients, in order to have a true diagnosis of inclusion body myositis, need to have a muscle biopsy. But we've been less restrictive on having all of the different features on a muscle biopsy. And so we're excited about this. We presented this at a recent myositis meeting, and we're excited to see how it performs with clinicians using it. And in addition, we hope that we've increased the number of patients that can be diagnosed with IBM, and I think that's really important. So this is that picture of the inflammation, and here's another picture kind of showing this inflammation. And what I like about this image here is what you can see is the inflammation is really attacking. It's called focal invasion, and it's invading a normal looking muscle fiber. And that's what's happening. That's an autoimmune disorder. And then we can actually see that these are different types of inflammatory cells. This is showing that these are actually, some of them can be macrophages, some of them can be T cells. And if we go even further, we can see that the muscle actually turns on something called MHC class 1 that says you should be attacking me. So your muscle is actually turned into a cell that is wanting to be recognized by these inflammatory cells. And finally, this is actually showing the cells that a new therapy is being targeted for. These are cells that we call KLRG1 positive cells. And so the other feature that we see in IBM is this degenerative pathology. And so this is a muscle fiber here where we can see a large aggregate here, inclusion, and we see this kind of vacuolated features. These actually, we can actually stain them with a variety of different proteins. This is a protein called SMI31. This is a protein called ubiquitin, where we can actually see that the muscle fibers are actually accumulating a bunch of trash. And so that's the two features that are happening. One is inflammation, and the other is this accumulation of garbage that's accumulating in the muscle. This is now electron microscopy This is actually a muscle fiber here, and you can actually see where these holes are right here. It's just accumulation of kind of trash that's accumulating. And then if we go even further, we can actually see that this trash is actually fibrils, which are similar to what we see in diseases like Alzheimer's disease and other diseases. This is just more examples of it. The other feature that we see is something where we see mitochondrial pathology. So mitochondria are the energy source for muscle to contract, and in IBM, for some reason, some fibers lose the mitochondria. So this is actually telling me that the mitochondria are actually absent and damaged in select fibers. And so we can see here again where they're absent in some fibers, they're starting to be absent in other fibers. And that's a very unique feature that we see in inclusion body myositis. So it's unclear why all three of those happen, but they help us understand the pathogenesis. And so is it due to a primary inflammatory muscle disease that leads to myofiber degeneration, or is it a primary degenerative muscle disease that then leads to reactivity of inflammation? And so there's actually evidence on both sides. 25% of patients with sporadic inclusion body myositis have an associated rheumatologic disorder, whether that's Sjogren's syndrome or lupus or rheumatoid arthritis. There's a genetic component that is on something called an HLA, and that suggests that if you have certain genotypes in an immune phenotype, that it is a risk factor. Rare patients with a variety of different infections, most notably HIV, can develop an IBM-like syndrome. This is very rare, but there are patients who clearly are much younger and at the time of their diagnosis of HIV are found to have an IBM-like syndrome. And then about 60% of patients have this autoantibody suggesting that it's immune. However, there are some features that suggest that it's degenerative. And so one of those is that it exclusively affects patients over the age of 50. So that's something that suggests that it's not due to just inflammation, but for some reason it's only happening as patients get older, similar to other degenerative diseases such as Alzheimer's disease and Parkinson's disease. It at present is refractory to any immunosuppressive medications. And so if you throw steroids on a patient with sporadic IBM, typically they don't respond in the same way that other inflammatory muscle diseases do. So we say that it's kind of refractory. The pathologies are very, very similar and clinically similar to hereditary forms of inclusion body myopathy. So to actually forms that are truly related to a genetic component and not sporadic. And in fact, some of these mutations that are associated with hereditary IBMs have been demonstrated to be risk alleles for sporadic IBM. So it's likely a disease that has both inflammation and degeneration. The question is, which comes first and how do we treat one or the other? And so there's been lots of work over the last decade or so on therapeutic targets. And I want to name a couple and even point out some that are in clinical studies right now. One of them being senescent T cells, another being pathways associated with degeneration, mitochondrial function, and then underlying muscle degeneration. And so this is a very exciting pathway which has been recently discovered, and there is a therapy that we'll talk about. This is the Abcuro study in inclusion body myositis, but it was identified. The idea was that there are T cells, and that these T cells, as they get stimulated, so a T cell is a cell that's an inflammatory cell. It recognizes something that it recognizes as bad. So it recognizes what we call an antigen. You could think of that as a virus or something like that. And then it expands, and every single time it's stimulated, it differentiates more and more and more and more, and it turns into what we call these terminal differentiated T cells or senescent T cells. And one thought is that these T cells which we now know are in inclusion body myositis muscle, that the reason that other inflammatory medications don't work is because we're not targeting this specific subpopulation. And that's what the drug for Curo is doing. And we'll talk about that in a minute. The other is, can we improve that accumulation of trash that accumulates in the cell? And so that's by inducing autophagy. And so people may be familiar with a study that's looking at a drug called rapamycin. Rapamycin is thought to enhance autophagy, and that perhaps that is enhancing the turnover of these protein aggregates that are accumulating in skeletal muscle. Another approach is actually to help fold the proteins. So we showed you that those proteins aggregate. Well, they aggregate because just like a piece of paper can fold, it folds and then it can fold into a point where it becomes a tight aggregate. And so if you can help the folding, perhaps you can help. And so that's what the drug arimoclomol was thought to be helpful for. It did not prove to be beneficial in the clinical studies, but that was the therapeutic target they were going after. And finally, another approach is to improve the mitochondria. And so there is a study out there looking at a drug called pioglitazone. It's actually a drug that's used in diabetes. And it's thought that perhaps this drug could be beneficial by enhancing the number of mitochondria that are present. Because I told you that the mitochondria are damaged, and that perhaps improving them would be beneficial. This is a study that hasn't really gotten off the ground too much yet, and whether it's beneficial is unclear. And then finally, focusing on what we call myostatin inhibitors. And so this is actually a cattle that actually have a myostatin mutation. Myostatin is a drug that regulates how big muscle can be. So you can't just get muscle that's larger and larger and larger and larger. It's actually a negative regulator of muscle size. And so that's what this, there are drugs out there that inhibit that pathway and lead to enhanced muscle size and growth. And so just to let you know, there have been many clinical trials for inclusion body myositis. And so these are a variety of them that have been out there, including arimoclomol, an approach to actually look at the myostatin pathway. And so I always want to put this up there because I don't want patients to think we're not doing anything. Two studies that we've been involved in. One is a study that we call Inspire IBM. This is a natural history study. This is really important. A natural history study is important because it helps us understand how patients progress, because we can actually mock a clinical study and know that over a course of 2 years, this is how far somebody would progress. And so it's really an important question. In addition, it's going to help us understand what this autoantibody does. This is the drug that's being used by Curo. So Curo licensed a drug that attacks a specific form of T cell called KLRG1. And so they have been enrolling. They actually just announced that they've actually completed enrollment. And so it was amazing that they were able to get 230 patients over the course of a few months. And it really speaks to the myositis community that patients were able to actually be enrolled so quickly. Just briefly, what is a clinical trial? So, we have several studies that are preclinical. These are not done typically in humans. Then there's a phase 1 study. And so there was a phase 1 study, for example, for the Curo drug, where they just tested to see if it was safe in patients. And so that's done in tens of patients. So even less than that was done initially in 5 patients and then later done in another 10. We then do a phase 1 or 2, or in this case, a phase 2 and for the Curo drug. And that's really to see if it's safe in patients, to try different doses. Because it's a rare disease, they're actually merging these together, where they're actually going to look for efficacy in patients. And that's something that we're doing more and more of. this is an example of what we do for preclinical studies, doing natural history studies, looking at biomarkers. I'm going to skip through that really quick. People often ask, how do we design a clinical trial? And something that's very unique for a clinical trial is you actually have to know the question you want answered before you even start the study. So you can't just give it to patients and see how they do. You have to actually give it to patients and say, I think they're going to improve on this function test in this time period. You're not allowed to change it at a different time. And that's because of how the FDA wants things regulated. So you need to know what the endpoint is. And so sometimes we use something called an IBM FRS. You need to know how long you're going to do the study. You need to know how many patients you want. You need to know what type of patients you want enrolled. So what type of functional ability and their inclusion, exclusion criteria. Often these studies are done as a randomized placebo-controlled trial, so a 1-to-1, but it's become clear that in rare diseases, this type of parallel design is not entirely fair. And so people have been designing studies where we do run-in designs where everybody ends up getting on drug, or crossover designs. This is an example of an adaptive. So normally you would design the trial, you would do the intervention and analyze. And newer studies are actually reviewing the results as they go through and then reanalyzing the studies. And even better approaches are doing things where one patient can serve as a control for a variety of different studies. And patients start rolling over into different treatments. And so that's what they're doing in ALS. And it's something that would be really great to think about doing in myositis. There are several secrets to a successful trial. One is that we need to know the natural history. And so that's something that those early trials are helping us understand. You need to be blinded to your treatment. So patients often want to know, am I on study drug? I don't know. No one knows. It's just something that can't be there because it will ruin the study. You need to have a clear biomarker. The last thing I want to do is treat with a drug and not know if it did anything. And so I at least want to know that it got into the tissue. I want to know that it did what the drug said it was going to do. For example, deplete a certain form of cells. And then finally, the way that we design them are, as I said, to kind of understand each of these different criteria. Some errors that we see are that some studies will change the primary endpoint to match the conclusion. This is something you can't do. They failure to account for other variables. So for example, co-administration of another drug or an exercise intervention that all of a sudden some patients on study drug are doing. Failure to prove that the drug actually got into where they thought it was. Assuming that patients progress in a linear manner. So that's something that needs to be taken into account. Inadequate sample size, choosing the wrong endpoints, and even loss of research subjects, and then they remove that from the study. And so that's something that can't be done. So I'm gonna end with this, and I'm happy to answer any questions. I know it was predominantly focused on IBM, but I'm happy to answer any questions about anything else.
Well, I think you already pretty much talked about the particular question I put in there about research, but if you could answer that question right now, just so it could be recorded before other people ask their questions in one place. Do you see it?
I do. Yeah, so
Okay.
the question was kind of, what are we currently working on in myositis research? And so one area that we're interested in is the aspect of so a couple of things. So one is being involved in the clinical studies, and so one of them is the INSPIRE study. The other is the Accuro study. The other thing we're interested in is we're very interested in genetic modifiers of disease and understanding why some people progress differently than others. And that's been a hard thing to do without actually having a sample set of patients that we know have progressed more rapidly than others. And so we're doing genetic studies on all of the patients that are enrolled in our clinical studies so that we can then match those that progress rapidly, those that progress more slowly, so we can start to understand kind of those types of modifiers. And then the other things that we're interested in is we're interested in activating autophagy, so activating that pathway that can help get rid of the trash that's accumulating in muscle. We think that at the time that patients present to me or to clinic, the treatment of inflammation is too late, and what we're left with is the degeneration, and that we need to focus on improving that degenerative phenotype. And so we're working with some companies to use some small molecule drugs that activate autophagy specifically in skeletal muscle. And so that's another approach that we're doing.
That is wonderful. Thank you so much. I'm going to stop recording now. And then Dave, you can take over with any questions that the people have. If you want, you can raise your hand or you can just speak up.
Okay, well,